And we are live. It's Dr. J here in the house. We have Evan Brand here as well. Today, we're going to be talking about abdominal pain, different types of abdominal pain, and what it could mean. And we're going to give you the functional medicine kind of clinical perspective as well, and give you some action items of what could be the root kind of deeper underlying cause of it all. Most people on the conventional medicine side will just look at surgery and drugs and acid blockers or pain medication as your alternative. And we're going to be looking a little bit deeper. Evan, how are we doing today, man?
I'm doing wonderful. It's
Excellent.
crazy to think about all the different possibilities of stomach pain. You know, we hear this from our clients all the time. Hey, I've got stomach pain. That's one of my complaints. That's why I'm coming to you guys. Please help. And then the question that we always ask right back to them is, well, where is the stomach pain? Because you could say stomach pain and it's like, okay, is this the lower right? Is this the lower left? Is this the top, like right below the rib cage? Is this under the right side of your rib cage? And depending on the location, that could mean a huge different range of problems. It could be something very simple, like you have low stomach acid and maybe you've got some heartburn, to you've got diverticulitis, or you've got some type of bowel disease, or you've got appendicitis. So where should we start? You want to start at the very top of the gut and work our way down?
Yeah, let's start at the top and work our way down. So let's kind of give people a physiology review. And then where there are, let's say, inconsistencies in the physiology, that's where symptoms start to happen. So remember, everything emanates from physiological imbalances, and those imbalances, symptoms increase and progress, and then eventually pathology may progress. Some people, it takes years, depending on how acute or how traumatic the injury occurred, right? So the upper area off the bat on the left side to center is going to be more of our stomach type of symptoms. So on the left, we could have, on the further left here, we could have more pancreatitis symptoms. Now, pancreatitis, most of the time is going to happen with a strong history of being an alcoholic. You can also have potential gallbladder stones that work their way out, and that as they work their way out, there's a place where the gallbladder and the pancreas kind of connect. And if that stone happens just below, it's possible it could back up the pancreas. So your big issues with pancreas are going to be a potential gallbladder stone or being alcoholic. And there's also other types of rare infections that could drive it. But those are the big two on the pancreatitis. Now, on the left side, it's greater likelihood that that's going to be a stomach issue than it is a pancreas issue. But it's good to keep that in the back of your head. As you go midline, it starts to mean that it's probably more of a stomach issue. Dyspepsia, that means indigestion. It could be inadequate stomach acid that's driving a lot of it, meaning you're not having enough stomach acid, you're not breaking down your food. Dyspepsia, which means poor digestion. And then, of course, from that, we can have heartburn because we don't have enough stomach acid. Our esophageal sphincter will not close. Food may rise up from the rotting acids in our tummy, and that can create heartburn. That can create inflammation in the stomach. And then, of course, the more inflamed our stomach is, the nerves that go to the stomach area are on a 2-lane highway to other muscles. And one of the other biggest muscles is going to be the crura of the diaphragm. So that crura of the diaphragm can rise up, or I should say the stomach could actually rise up and pop above the diaphragm. So if here's our diaphragm, here's our stomach, it could pop up and go above it. And that's called a hiatal hernia, and that can affect digestion too. So I'll just kind of lay out those couple of things and I'll let you comment. Go ahead.
Yeah, I had a hiatal hernia and I had an H. pylori infection. So for me, the top center of my gut, right below the sternum, that's where, when I did have stomach pain, I would say this is a common area. I'm going to say at least 50% of the people we work with, if they're going to complain, we're talking the patient population that's complaining of stomach pain, I'd say half of them are talking about this midline right under the sternum. And it could be H. pylori, the whole heartburn piece, and then, potentially the hiatal hernia. I felt it. It was bad, but luckily I had a chiropractor who was able to do the visceral manipulation on it and kind of pull it back down. It was not fun, but it was almost instant relief.
Yeah, the manipulation is super helpful. You can do it as well by swallowing some water, lifting your hands up, going up on your tippy toes, and then dropping down to your heels and dropping your hands down. And that can help too. Basically, if here's your diaphragm and here's your stomach, you're lifting this up, which essentially lifts everything up, and then you're dropping it. So you're trying to create momentum to kind of pull that stomach back down. And the visceral manipulation way is the more specific way, but that's just a good side thought. So kind of highlighting things, we have basically inflammation in the stomach. And remember, inflammation in different ways is where the diagnosis gets labeled, right? Hiatal hernia, it's more specific to the stomach raising up. Heartburn and dyspepsia tend to be intimately connected. If you have poor digestion, eventually there's going to be some level of heartburn. And then gastritis is just inflammation of the stomach. So if you have poor digestion, if you have a hiatal hernia, if you have dyspepsia, that could definitely emanate. And then you have the extreme where you have an ulceration, which is essentially a cut inside of your stomach. And typically that gastric mucosa has been worn away because of poor digestion, stress from food, stress from H. pylori or SIBO or SIFO, and all those things, fungal overgrowth can emanate in the stomach as well as the small intestines too. And all of those things can be kind of at the root. And then as you move more to the right, this tends to be more where the liver and the gallbladder are. So your liver's going to be like this right here.
And when he's saying the right, just for people listening, when he says the right,
it's the person. It's your right. So not not reader's right, not you looking at someone and your right as you looking, but the actual person's right.
Yeah, you looking down at yourself, down to your right. There's your
So if you write with your right hand, right, that's going to be your right side, and your liver is going to be right in this area, like this. It's going to be basically like this shape, or it's going to be, I think, this shape here, right here, like this. It's like a triangle almost kind of shape. And right tucked in underneath the liver will be the gallbladder. So typically you have the gallbladder right underneath it. So most people, when they have pain in their liver, it's going to be a gallbladder pain most of the time, unless there's a lot of cirrhosis happening from alcoholism, or you could have a lot of non-alcoholic steatotic hepatitis, NASH, or non-alcoholic fatty liver. And that's typically going to be from excess fructose. Fructose is going to be excess fructose, which is a sugar. It's a fruit sugar. It's typically half glucose and sucrose. But I'm saying a half glucose and sucrose. But with today's modern fructose, it's a little more fructose. And fructose preferentially gets metabolized in the liver. And once your liver is kind of stored up of fructose, over time, you have a lot of inflammation enzymes that can upregulate, like the JNK1 enzymes. And those enzymes can create a lot more inflammation in the liver, typically from fructose. There's also various like hepatitis markers, like hepatitis A is going to be like a food poisoning one. Hepatitis B is more like an STD one. Hepatitis C is going to be more like, I think, like needles and stuff like that. So yeah, hepatitis infections could also be partly at play too, but your more likelihood is going to be alcohol, and the most likelihood now is going to be a non-alcoholic fatty liver, and that can be reversed. We monitor liver enzymes like ALT or AST or GGT for the gallbladder. That gives us a good look at what's happening in the liver from a conventional mainstream look, and then we can also do ultrasounds to dive in deeper if we're concerned there could be a problem.
People may think you're just making stuff up. If you're like, your Diet Coke, or well, I guess Diet Coke wouldn't have sugar, to have aspartame. Let's just say Coke. Your Coca-Cola is hurting your liver. People are like, oh no, give me a break. How's it hurting my liver? Well, there you go. It's the non-alcoholic fatty liver disease due to the fructose in there. So it's good that you point out the connection, because if you talk to your average person standing on a street corner and say, hey, do you know that your Coke is causing liver damage? They're going to be like, no way. There's no way.
I know, it's really sad. And the end stage liver enzyme markers, they're end stage. They kind of come up a little bit late in the game. We like to look at a lot of organic acid markers that can look at glutathione. It can look at a lot of these sulfur amino acids involved in phase 2 detoxification, or a lot of these antioxidants involved in phase 1. So we kind of get a window into these things before there's a problem, but we understand the foundational physiology and we understand the imbalances, and fructose is going to be a big one. All right. Fructose is going to be a big one. So just keep that in the back of your head. Anyone listening, I saw 2 patients last week with fatty liver. So, we're monitoring their insulin levels. We're keeping the fructose out, just keeping it to non-starchy vegetables. And we'll look at those liver enzyme markers and make sure we get them under control.
And you can reverse it. I mean, you
can. Absolutely.
We have different herbs that we use that are specifically for this whole hepatic system. And we've seen the markers turn around and people feel better, and then they no longer have that diagnosis. So that's the good thing, is if you give the body the right nutrients and tools,
yes,
you can heal it.
Oh yeah, 100%. I mean, it takes a little bit of a commitment, but you can definitely do it.
Yep. All right, let's move on. So we talked about all the top stuff. Let's go like midline area, or I guess you wouldn't call it midline. You'd call it center of the tummy, belly button area, all around in there, each side of the belly button.
Yeah. So let's go into that next. That's a great
There's
question.
actually something is I want to say, let me look it up. Was it called Murphy's sign? You know, I
Yeah.
had a
With Murphy's sign, that's going to be your gallbladder sign.
okay. So
So like typically you kind of come like this in school. They teach you, you come at it here with your fingers and you kind of go under the rib cage. So it's so here's my rib cage here. I'm pressing underneath and basically I'm breathing in. And as I breathe out, I'm working my fingers up there. And if it's a gallbladder issue, you know, you're going to see some pain and tender feelings there. I mean, no one's going to use that as a full-on diagnosis of a gallbladder issue. They're going
yeah,
to go refer you out for an ultrasound. They're going to run a metabolic panel and look at liver enzymes and gallbladder enzymes. And they will also maybe even do a HIDA scan where they look at, you know, biliary flow as well.
I
But I
like
mean,
those old school tests. I mean, the history of that. Dr. Murphy, I mean, we're talking, this was invented, that Murphy sign was like the 1880s is when that
yeah,
came out.
I mean, if you look at old school doctors were much better clinicians than today's doctors because today's doctors, they just rely a lot more on lab testing and diagnostic screenings like ultrasound or MRI or CAT scan or X-ray. So there was a lot more functional test. I mean,
More hands-on.
yeah, a lot more hands-on functional tests. I mean, how about the best one, man? How about the one? I mean, this is the one I think you should bring back for your clinic is when they were looking at for type 2 diabetes, right? They would actually have the person pee in a cup and the doctor would then taste it to see if there was any sweetness in the urine because diabetes mellitus meant something like sweet tasting urine. So the clinician would actually taste the patient's urine to see if there's any sweetness to it. How about that?
That's a trip. I'll let you take that one. I'm going to
No,
pass.
dude, I'm going to start doing videos for you and get patients in. Hey, Evan will diagnose your diabetes, lab test free.
Oh, goodness. That's crazy. Now, there was another test. It wasn't Murphy's. Maybe you could remember this. I want to say it started with a C as in Charlie. Around, you know, I took a course on some functional hands-on palpations, and it was around the belly button. Like there were different palpations you would do around the belly button. It was one of these other old school doctors. I want to say it was with a C, but I can't remember right now.
Yeah, there's a couple. So there's like these points right here. So like in applied kinesiology, on the left side was the hydrochloric acid point, and on the right side was the enzyme. And how I remember it is HCl, the L in HCl, I think of left. So left. And then the enzyme one is the right. So it could be one of those points. So if you kind of rub here and it's really tender, that can mean an HCl issue, or you rub on the right side and it's tender, that could mean an enzyme issue. And again, I'm always giving hydrochloric acid and enzymes together anyway, but just food for thought, just something to think about.
Yep. Yeah, I don't have any on the school references with me, but it was pretty cool, at least in person, because you could correlate these different pain areas on a palpation with the type of issue. And so some of the students would be like, "Oh yeah, I do have bacterial overgrowth," and then you hit that point. "Ooh, yep, you sure do. You're sensitive."
Exactly. Now, if we go to the middle area, right? So we had the upper quadrant, right? Left was kind of a little bit more pancreatitis, some stomach, gastritis. Middle was more hernia, but still stomach and ulcers. And then right was more kidney, gallbladder area. Well, now we go middle row, the middle outside areas, that could potentially be our kidneys. Now our kidneys are deeper. So a lot of times that pain, that flank pain will emanate deeper in the back. So usually kidney pain will be more in the back. But on the front, you're going to see potential any level of inflammation in the intestines, you're going to see emanate at this level. All right. So if you have any issues here in the midline, this could still be pancreatitis issues. This could still be any type of bowel inflammation, Crohn's, any type of bowel or any type of intestinal inflammation. Bowel typically refers to the colon. Any type of intestinal inflammation, you're going to see more midline in the belly button just lower than belly button area. Once you go on the outside, this could easily be ascending and descending colon. So essentially the colon leaves on the left. So this is going to be your descending colon leaves left, and then your ascending colon is the right. You have a transverse colon, but that's a little bit, that's a little bit deeper. And then as you go lower, you're going to have your pelvic issue. So on the lower right-hand side, this is going to be where your appendix is. And then on the midline to left side, this can easily be deeper colon issues. So any type of ulcerative colitis issues, sometimes Crohn's can affect the colon more. It's small intestine, but sometimes it can stagger the both. And then you could have all this various colon pain, colon inflammation, diverticulitis, any type of gut inflammation that's colon based is going to be in this area. And then for some women, midline, there could be endometriosis in these areas too. You're going to see that tend to act up more around your cycle though. So you have to look for timing of that acting up around your cycle. You could have endometriosis issues. Guys, that won't be an issue, but any type of IBS or irritable bowel stuff or colon inflammation stuff like ulcerative colitis, or bottom right-hand quadrant will be your ileocecal valve and your appendicitis symptoms.
Yeah, I remember when I was a kid, my dad would be in severe pain and he always had his hand over on his left side over there, and he ended up having to have some of his colon cut out. You know, he had really bad diverticulitis when I was a kid and ended up in surgery. They cut out like a foot. You know, so it sucked to see how much he suffered. His diet was just terrible though.
Yeah. I mean, with diverticulitis, that's basically the little diverticuli. They're literally little herniation outpouchings where things can get stuck in there, various foods. It tends to not be an issue until bacteria goes out of balance in your gut and food becomes more inflammatory. Now it becomes more of a problem where like things like seeds or nuts can stick in it and such. Tends to not be caused by those issues, but the more inflamed your gut gets from other diet and lifestyle factors, then those foods can cause a problem for sure. And obviously not enough good healthy fiber can create colon motility issues. And if you can have stool compaction where that your bowels aren't moving and then the stool gets backed up and create pain and gas bubbles that way too.
Yep. And if people hear a little tiger in the background, that's Dr. J's cat.
That's Dexter. I know. Hey, Dex.
All right, so let's go to the low area now. So like low right side pain. I mean, I could have swore like I was having appendicitis one time. I mean, it was such severe pain on my low right. I thought, okay, I'm going to die. It's appendicitis. Luckily, no, it was probably just my ileocecal valve because after I did some stool testing, I had some bacterial overgrowth problems. I also had some parasites at that time. So maybe we should talk about that, kind of the infection connection here. We talked about H. pylori up at the top.
Yes.
Infections could also be, I mean, really anywhere, but we're trying to be specific. But the low right area, that to me is like a parasite area as well.
Yeah, ileocecal valve is a big one because that's where the small intestine meets the colon. So you have duodenum, jejunum, ileum. Those are your three parts of your small intestine. Duodenum's the top, jejunum's the middle, ileum's the bottom, and then the ileum then goes to the colon on the right side, and that's the ileocecal valve, right? So it's cecum on the colon, then it goes up to a ascending, transverse, descending, and then sigmoid comes down and deep in the middle. Now, in the middle, at the very bottom, this is where it could be a prostate issue too. It could be a bladder issue as well. It could be a deeper ovarian cysts, endometriosis issue as you know, if you're a female. So you got to keep those different things in there. And of course, like Evan was alluding to, is anytime you have a parasite infection, these things can emanate in different parts of the intestinal tract and create inflammation. And there's no kind of, hey, this is the area where parasites go. They kind of have free reign. So just keep that in the back of your head. A parasite issue could create pain in any of these areas, and it's totally up for grabs.
Yeah, we do know that Giardia can affect the gallbladder. So I would just say as a general rule, if you're looking down on your right side, so under that rib cage on the right side, working down towards the appendix, that's where I had pain and I had Giardia. So if you have infections, if you've had bad water, bad food, or you just, most of your pain's localized to the right, I'm not going to say 100% because that's not what this podcast is for, but that would say, hey, that's enough symptoms for you to justify getting some functional testing done, potentially an ultrasound as well. But in some cases, you may just need a really, really good DNA-based stool test. We can look at these infections, come up with a protocol to address them and dialing in the diet. And then that pain magically might just go away.
100%. Yeah. Always good to keep an eye on all those things. And that's why it's good that you work with a good functional medicine doctor, because food allergies can cause a lot of these problems too. You're going to see more food allergies kind of emanate in the upper to middle quadrant areas, but sometimes you can see it lower quadrant. I had a patient
when you say
with
food allergies, we're talking what?
Gluten sensitivity, inflammation from gluten, inflammation from foods. But the most common ones are going to be grains, of course. And then you can see even dairy create problems. And then you have more of the autoimmune food allergens, which are going to be eggs and nuts and seeds, and those can create problems too. And you're going to see them more in the upper and middle quadrants, but sometimes they can work their way down to the colon as well. It's possible. I've seen it. And like you mentioned, different parasites can work their way down there too. And typically just having bad digestion, you start to see that in the middle to upper quadrants, because usually it starts with poor hydrochloric acid.
And the
Usually if
nightshades
someone,
too, tomatoes, peppers,
yeah,
those could be.
tomatoes, peppers, yeah, all those can have a problem. With digestion, you tend to see the first domino tends to not fall correctly. And that first domino is not enough acidity and then not enough enzymes starting in the gastric tummy area and into the upper small intestine. So you start to see it here. It's very rare to have good digestion starting off and then it goes bad downhill. It tends to be, hey, we start the domino rally correctly and then all the other dominoes kind of fall in place, so to speak.
That's a good point. Yeah. So just to say it another way, the dysfunction will probably be evident at the very most north starting place. It's not, you're not likely to have just a, southern gut issue. It's probably going to start up here, and then down there you may have problems as well at the same
Yeah,
time.
where you see more southern gut issues, it typically is going to be like a diverticulitis thing.
Okay.
A lot of times could be a parasite, could be an appendicitis thing. I've seen it happen, but just kind of a generalized rule of thumb of what I see on average.
All right, here's one thing that we forgot to mention, because there's probably a couple moms listening, screaming at us, saying, "Oh my God, you're not talking about diastasis recti." So
Oh, well,
yes,
yeah, that's
if you've had babies, yes, you could have some scar tissue up in there. Justin's somebody who educated me all about myofascial issues, and so there could be some myofascial / scar tissue in that area as well.
yeah, it's all about history. So if someone's just had a baby, that's different. Some of the, the more cutting edge surgeons, they'll even put a couple of sutures and when they're taking the baby out afterwards, or if it's a C-section, if they're going in for a C-section and they're already in there, they'll put a couple of sutures in that midline just to kind of keep that muscle together a little bit so it doesn't separate. Basically, imagine the six pack, so to speak, the midline of the six pack kind of separates and you can have a little bit of bulging there. And that's almost always going to have a pregnancy history with it for the most part.
I didn't have any babies, but I had that pain because I got.
Yeah, but you didn't have the full separation where there was a bulging out.
No, I never had any bulging, but I just had a lot of midline pain that I thought could be related to hernia. But after I got an abdominal ultrasound, they said that I did tear the abdominal wall. And it's because I was using improper form. I was lifting super heavy kettlebells, like 90-pound kettlebells. I was lifting those out of a crate to pack those up when I was working down in Texas. Just dumb, lifting heavy stuff, improper form. And I really did a number 2 to that abdominal wall.
Yeah, exactly. And then for someone like for you, you're working on with a good myofascial release or an active release person, kind of breaking down that scar tissue. And then, then you're working on better form with good abdominal bracing to activate that TVA kind of ahead of time. So that's good.
Yeah. So heavy lifting, people listening, if you're into CrossFit or whatever else, you're lifting heavy rocks or crazy stuff, make sure that you're doing it with proper form. Cause I'll tell you, after having an abdominal wall injury, it really limits what you can do. You don't realize how much you use your abdominals until you injure them.
100%. Anything else you want to highlight so far in regards to the abdominal area so far?
I think you did good mentioning the bladder stuff. You mentioned the ovarian cysts as a possibility. What about fibroids too? Wouldn't that also be kind of same area?
Yeah. So we have endometriosis is going to be basically endometrial tissue growth outside of the uterus. So you're going to see that could be on the outside of the uterus wall. It could be or the outside of the uterus. It could be on the bladder area. It could hit some of the intestinal area. So that could hit in some of that lower quadrant, and you're going to see that more flare up around premenstrual and menstruation time. So you're going to see a timing there. And obviously that's going to happen with women only. And then fibroids as well. That's going to be more in the uterine area. So that's going to be right in that pubic bone area, midline, because the fibroids can contract a little bit. And if they're intramural fibroids, meaning there's kind of sandwich in between the muscle, then you feel it a little bit more. If they're subserosal, it's in the uterus. If they're a peduncular, they're going to be at the top. If they're there's one more kind where they're on the outside. I think it's it's on the outside. So you'll just feel it a little bit more lateral, so to speak.
Okay.
And you'll see it happen, and you'll see it happen more around premenstrual, leading up to bleeding to during bleeding.
Okay. That's important. A lot of women listeners. So the inguinal hernia, I mean, yes, like I said, when I thought I had a hernia, that was the area. They said, yep, you could definitely have a hernia around here, but luckily I didn't. But it's super common. So, I mean, tons of people are getting those mesh surgeries, and then they're having tons of complications from those. So I'm not an expert at hernias or surgeries, but my limited knowledge of it says to do the mesh free. If you're in the situation of a hernia in that area, a mesh free surgery sounds like there's less complications as doing the mesh.
Yeah, and with the fibroids, it's the submucosal is at that mucus lining inside the uterus. The subserosal is more superficial, more on the outside, just
Okay.
for any of the clinicians listening.
Sweet.
All right, cool. So we hit all the female stuff. Of course, ovarian cysts could be a big one. That'll be a little bit more lateral. All right, a little bit more outside. It'll be more right where the ovaries are. So ovaries are going to be a little bit lateral to the uterus. And that same thing will be timed up more on premenstrual and or menstrual. And you're going to only ovulate from one ovary. So it's typically going to be bilateral. It's going to be typically unilateral, one side over the other. It won't be both sides at the same time.
Ah, that's a good point. Good
Yep.
key distinction. Okay. How about, if you're ready, why don't we talk about testing? Some of the things that we would do from a functional perspective. We mentioned the conventional already, like the ultrasound, abdominal ultrasound.
Correct.
You've got like a barium x-ray scan where you drink a disgusting drink and they do an x-ray to look for different issues in the upper stomach, like
Correct.
ulcers, which I've had done at one point. But the functional testing, I think, can help us in a lot of cases to look at the inflammatory markers, the gut barrier function, bacterial overgrowth. We could test for parasites and candida overgrowth. These things are key.
Yeah, I mean, you're going to have like your barium swallow, radioactive drink, looking at the esophagus and making sure everything's moving down that pathway correctly. You have a HIDA scan where they're putting something intravenous into your body that's radioactive and taking pictures and making sure everything flowing out the bile ducts and the gallbladder and all in that intestinal area is flowing properly. So it's just giving you a window into that part of the anatomy to make sure everything is moving appropriately. They're looking for obstructions, fistulas, just things that would prevent generalized flow. Maybe a tumor is blocking something. So they're trying to get a window into big picture pathological things. Maybe a gallbladder stone, right?
Yeah.
Could be causing the pancreas flow backup issues like I mentioned earlier. So they're just trying to get a window into ruling out big picture physiological issues. And then of course, we have things like the ultrasound, which can be used to look at the gallbladder area and the liver area to pick up stones or potential, non-alcoholic fatty liver. You can even look at the kidneys a little bit too, or even the prostate. It's going to be a different kind of ultrasound, but yep, you'll be able to look at those too. So that's good ways to visualize it. And then of course you have your generalized blood markers. So we can look at glomerular filtration rate or BUN or creatinine to get a window if there's a kidney issue. If we're potentially concerned there could be a UTI or a bladder infection spreading to the kidney, we can always run a urinary test, like a microscopic urinalysis to look at various bacteria or white blood cells or things that could be affecting the urinary tract, bladder, kidney area. So those are all very helpful too. And then gallbladder, or I should say prostate inflammation, there's your favorite digital exam, right? Finger up the butt, feeling for any inflammation or swelling. And then we can always do a PSA, which may be non-specific, and then even do an ultrasound too.
Yeah. And then you may have to go further, something like these are not tests that we run, but like your CT scans, your CAT scans,
your MRI to look at. And these are going to be more to look at bigger picture growth, bigger picture stuff. And a lot of docs may just start off with that just because they want to rule out the bigger picture stuff right away. So you have your CAT scan and your MRIs, which are going to be big picture.
And hopefully it doesn't go that far, but if you end up getting those things, sometimes you find bad things that you don't want to find, tumors and different issues. So on the
and then we
side,
shouldn't forget about, the generalized colonoscopy or endoscopy. Endoscopy camera down the mouth, colonoscopy camera up the rectum to look for masses, bleeding, ulcerations, and or just generalized inflammation. The problem with it is it doesn't tell you root cause. Hey, you have gastritis. Hey, you have inflammation in the intestines. What's the cause, right? So the problem with a lot of these testing is unless it's acute, like an ulceration or a big tumor, that's important to know right away so it can be addressed. But most people, it's an in-between kind of thing and the root cause isn't addressed. And usually there's some kind of an acid blocker or pain medication or antispasmodic or antidiarrheal or laxative. It's typically recommended to fix the problem, or not fix it. Really, it's to manage it, right? Most gastro docs are just, once they've ruled out big picture disease stuff, they're primarily just managing symptoms for the patient. And then you got to deal with, well, do you really want to have your diarrhea managed for the rest of your life, or do you want to actually get to the root cause? So you have to weigh those things out. Most people want to fix the root cause.
Yeah, it's a revolutionary idea, which it shouldn't be, to fix or find the root cause.
Yeah, I
Speaking
mean,
of,
it's kind of like you got a flat tire. Do you want to manage it by riding on your spare the rest of your life, or do you actually want to get a new tire and fix it from happening, kind of thing?
yeah, I find mechanics are far more root cause than doctors. Isn't that interesting? And veterinarians, same thing. First question: what kind of cat food are they eating? What kind of dog food are they eating? That's like the first question.
Yeah, the interesting thing, someone said, what's the difference between a mechanic and a doctor?
I don't know.
Well, the mechanic actually gets to turn the car off. The doctor can't. So the car's running all the time, as the clinician, right? So you get a big advantage when you get to turn the car off,
This is
so to
true.
speak. Yep.
This is true. All right. So speaking of heartburn drugs, and then I want to make a comment about the endoscopies. So CVS over the weekend pulls Zantac and similar heartburn drugs because of the cancer concern. So time and time again, I mean, over the last year, you and I've kind of watched this thing unfold with all of these H2 blockers, these PPIs continually getting recalled and pulled off the shelves due to cancer links. And so they're saying, oh, well, a study said, there's no markedly increased risk of cancer. Basically, they don't have a clue. They don't know. There's some studies that are saying, yep, cancer from PPI. Some are saying maybe. Some are saying, we don't know. We haven't had a long enough trial. So once again, though, it's not root cause. So rather than debate whether or not acid blockers cause cancer or not, figure out why the heck do you need an acid blocker in the first place? What's causing you such bad gastritis in the first place? Maybe it's an H. pylori infection. If you fix that, you won't have to worry about, am I taking an acid blocker that causes cancer, or is this a safe acid blocker? So that's my comment. And then,
and I'm
yeah,
not against acid blockers in general. For real acute stuff, it can be very helpful, but I only want to use it very acutely as we get to the root cause and put out the fire. I'm okay if it's a quick stopgap measure, but the problem is once you're on it and you're not getting to the root cause and that tissue stays raw, it's hard to get people off it. So you just got to keep that in mind. We want to have a root cause perspective, but we don't want to be so anti-drug where, maybe these medications could be helpful for a day or two or three to get you through to the next step. But most people aren't using it as a stopgap. They're using it as a lifetime crutch. So just kind of have the right mindset when you go into these things. I don't think you have to be totally puritanical. Although if I have a heartburn episode, which I typically don't, I'm using enzymes first, and then I'm using more natural kind of soothing things second. But if I needed to do a little bit of baking soda to chill things out, I would and I could if it was affecting me from sleeping. But I have my first line therapies that are more root causal that address the issue first. So we got to keep those in mind.
Yeah, and the problem is when you get on those prescriptions, there's really not an end game. It's not like, hey, just do this PPI for a week. It's kind of like, okay, here's your PPI. I'll see you in 6 months. And there's no discussion of when are we going to get off of this? How are we going to get off of this? Is there a weaning protocol? As we reduce PPIs, are we going to increase HCl? None of that's discussed. And then my comment on the endoscopy is that there's a big problem with the scopes not being cleaned properly.
Yes, that's a big issue. Yes, Dr. Mercola had a guy on this topic. Yes, go ahead.
Yeah. So the problem is you go in to get a routine procedure like an endoscopy, and then you leave the hospital with some type of they call it an HAI, a hospital acquired infection.
Yeah.
And that's crazy. So it's like, okay, I'm going to go in and just get the scope done. This sounds fun. And then you leave, and then now you've got some major infection that could really, really, really affect your health. So I'm not against the endoscopy. I think there's tons of things that have been helped by using those, but man, it's not going to be my first thing.
100%. So we got to keep that in mind. And also one more thing I wanted to mention there. We talked about endoscopy. We talked about colonoscopy. Oh yeah. One more thing. So a lot of people that have gut issues, meaning middle to upper quadrant pain, especially midline or to the left, a lot of times there's some level of inflammation in the gastric area or the gut, the stomach, right? Now that inflammation a lot of times gets better with some level of stomach acid, hydrochloric acid, but you have to be very careful because some people, their gut lining is worn so thin, they may need stomach acid, but they can't handle stomach acid. In other words, any of my patients listening, I give this analogy all the time. Imagine you have back pain, but you went out and laid on the beach too long that day and got a sunburn. So now you need a massage, you need a good adjustment, but the superficial pain on your skin from the sunburn is making the therapy much more uncomfortable to bear, the massage or the adjustment. So some people need to calm things down in the gut, before they can actually get that good acid support. So you have to figure out, are you that person with back pain and a sunburn? And we have to handle things a little bit differently. So most people may hear this and just jump on the hydrochloric acid bandwagon, and they may have negative symptoms. So be very careful. And I strongly recommend that you're doing this under the guide of a good functional medicine doc. And if you have a conventional medicine doc, make sure you just keep them in the loop so they know what's going on.
Yeah, well said. So there is a right place and a right time for specific nutrients. For example, the HCl you mentioned, also like probiotics. People may say, oh, I've got
They
gut
get bloated
pain.
and gassy.
Yeah, I'm going to go take probiotics, and then they have a bad reaction. Then they come to us and say, hey, why did probiotics make me feel like crap? And our answer is, well, because there's a right place and a right time. And based on your particular picture that we've identified using functional testing like organic acids and GI map stool testing and other functional tests, this is not the right time or the right place. So we'll paint that timeline of like, okay, yeah, HCl is good, but first we're going to do a month of gut healing support, then go to HCl, then use antimicrobial herbs, then possibly bring in probiotics. But if you mess 100%. Up that order, or if you just hear the buzzword or the, what do you call it? Like the clickbait, probiotics are good, HCl is good. You try to self-medicate and you feel worse, and then you don't know why.
Because I'm the king of analogies, I'll drop another analogy. I love analogies because it hits you and you never forget it. You're out in the garden, right? You're throwing down seeds before you did weeding. All right. Hey, you try to get your car waxed before you got it washed, right? There's an order in which you have to do things. So you try to put and add more beneficial bacteria to your gut, but you got a whole bunch of bad stuff already there. So there's a sequence that involves cleaning and getting things under control before you go to that next step. And how do you know? Is because you tend to get bloaty or gassy or brain foggy and don't feel good with probiotics. And if you're that person, then you know how and why.
Yep. Yeah. I was one of those guys. I tried to take probiotics and I failed miserably, and I had tons of stuff wrong with my gut. So I had to go backwards, and I did a wrong order. And this is just experimentation. You know, I've experimented with plenty of different things, and people send us stuff to try, and nope, not the right time. So I had to clear out my gut bugs first and then do probiotics, and I was fine.
Correct. Yep. 100%, man. Very good point.
I think that's all that we need to talk about. I did mention the functional test. I didn't know if you wanted to say anything else about potentially doing like breath testing for SIBO or H. pylori.
Yeah, it's a great question. So let's kind of work down. So we have our generalized breath test. The glucose breath test will be more for the stomach and the upper intestinal tract. The lactulose will be more for the entire small intestine. So those are your big breath tests. There's a urea breath test that's more experimental out, but we have the glucose and the lactulose that are primarily on the breath side right now. Then we have our really good stool test. There's different companies out there. BioHealth makes a 401H. Doctors Data does a 3-day sample with an H. pylori. We like a lot of the diagnostic solution laboratory ones, the GI map stool test. We'll put links below in case you guys want to grab one of those. So we like those. We'll also potentially run some blood markers for antibodies for H. pylori. We may even run a specific H. pylori urea breath test that looks at CO2 in response to H. pylori. We may also look at organic acid tests that look indirectly at urinary yeast via diarabinitol or rabbinitic, or we may look at bacterial markers in the urine like 2,3-phenylacetate, hippurate, indican, various urinary markers of dysbiosis. So we have those for the gut, which are really helpful. And then I would say, is there anything else you wanted to add? Did I hit it all?
I think that was it. You mentioned the stool testing, like I alluded to earlier. We're primarily looking for infections on there. So the bacterial overgrowth. Sometimes we find certain infections on organic acids testing that we don't find on the stool, and vice versa. Sometimes, like for example, the stool testing is not very good for finding candida, but the urine is very good for finding candida.
Better for candida, for sure.
Yeah. And then with the stool, that's where you're going to find more infections like bacterial problems. Sometimes the urine tests miss it. And then I already mentioned like the mucosal barrier. We'll look at measuring gut function, gut inflammation on the stool. So really with urine and stool, we can do a lot, but there may be a point where we do have to say, hey, you got to get an ultrasound. You know, there is a purpose and a point to the conventional diagnostics. I'm not against them, but
and I typically recommend all people that have any acute issue, you know, get your conventional MD to kind of sign you off first. It's always good because then you kind of know, okay, you know, the big picture stuff, we're not missing it. We're on the right track. And then we can go see Dr. J or Evan to dive in deeper at more root cause stuff. Also, I wanted to highlight one more thing you were just mentioning there. You were just talking about the ultrasound, you were talking about, oh yeah, one more thing. So I've seen a couple patients that have a lot of candida issues. And sometimes I'll even order full spectrum candida antibodies. So I'll run IgG, IgM, IgA. I found a person with elevated IgA antibodies for candida. So it's good to have those looked at, because then you can get a window into systemic immune activation of the immune system going after candida. It's good to know that.
Oh man, we didn't even talk about mold.
Oh yeah.
I can't tell you
Hmm.
specifically where the pain would be in your stomach, but Dr. Richie Shoemaker, one of the guys, has been treating mold illness for like 25 years. One of his symptoms that he's come up with is abdominal pain. And JW, who's been on the podcast from Immunolytics, he's spoken many times to me about his daughter, his
Hmm.
oldest daughter. And when she would go into a moldy building, her and her mother both would have abdominal pain, and that was their cue to leave. They would
Oh,
literally
wow.
be like bending over in pain. When they leave the building, their pain goes away. So that's another like unique symptom. And then we forgot to talk about the spleen a little bit.
Oh, spleen's going to be in that upper left-hand corner too, but go
But so
ahead.
like Lyme and co-infections, though, if someone has Lyme disease or co-infections, this can affect the spleen. And so if you had like a slightly enlarged spleen, that could cause pain. So we may be looking at doing some blood or urine testing for Lyme and co-infections as well, because that's one other thing that most practitioners are going to miss, but I've seen be very, very helpful.
Yeah, I mean, you'll see a lot of spleen stress with like Epstein-Barr. So knowing if you have any Epstein-Barr issues, increased chance of spleen rupture. And then of course, you're going to see potential low immune markers, lower red blood cells, where you can't figure out why. There could be a spleen issue going on there, or a bone marrow issue where you're not making enough of these good cells. Of course, just traumatic issues, right? Hits and stuff, car accidents, spleen rupture. Spleen's really important. It's going to be the recycling cavern for a lot of your red blood cells. That's good. And a lot of immune cells are made there. Excellent.
I think that's it. That was the only missing piece, I believe.
Yes, if everyone's listening here and really enjoying it, and something resonated with you, put your comments down below. What did you like? What experience have you had with specific abdominal pain? What helped it? What was the root cause for you? And if you're enjoying the podcast, give us a share and a thumbs up. It boosts up that YouTube algorithm and allows more people to get access to the information, and share it with one person that could benefit. If anyone wants to dive in deeper and they're like, yeah, I'm a little bit confused, hey, that next step would be click below and schedule a consult with myself or Evan, and we'll be there to help you and guide you in the process. And if you have a major issue, get it ruled out by your conventional MD first, and then reach out, and we're happy to dive in deeper at the root cause level.
Yep, well said. So check out the websites justinhealth.com for Justin. My website is evanbrand.com, and we'll talk with y'all very soon.
Excellent. You guys have a phenomenal day. Take care, y'all.
See you later. Bye-bye.
Bye.